So now we move on to one very important congenital cyanotic heart disease, that is tetralogy of Fallot. Very, very important. Okay. So this tetralogy of Fallot is the most common congenital cyanotic heart disease in children. Okay. Now tetralogy of Fallot, the name itself is telling you it is tetralogy. So tetra means 4. So tetralogy of Fallot has got 4 components. Very, very important. It comes as a question. All of the following are components of tetralogy of Fallot except. So we need to know what are the 4 components of tetralogy of Fallot, right? So the 4 components of tetralogy of Fallot, very, very important, are a large VSD, or it is also called large unrestricted VSD. Why is it called unrestricted? Because there is no restriction in the flow across the 2 ventricles. The 2 ventricles are acting almost like a single chamber. So large VSD or large unrestricted VSD. Pulmonary stenosis or pulmonary infundibular stenosis. So there is narrowing usually just below the pulmonary valve. Okay. So pulmonary outflow obstruction is there. So you can just remember pulmonary stenosis or pulmonary infundibular stenosis. Right? Another component is overriding of aorta. And right ventricular hypertrophy. So these are the 4 components of tetralogy of Fallot. So now let us see what happens in tetralogy of Fallot. So the right atrium, left atrium, so there are 4 components of tetralogy of Fallot as we said, right? So one we said is large unrestricted VSD. So can you appreciate how huge is this VSD? So the ventricular septum is just so little part here. The rest all is the VSD, the 2 ventricles. So this is the right ventricle and the left ventricle. They are communicating and acting like a single chamber. Then we said is pulmonary stenosis, infundibular pulmonary stenosis. So this is the pulmonary artery and this is the narrowing in the pulmonary artery. Okay, so this is the infundibular pulmonary stenosis, the narrowing in the pulmonary artery. Overriding of aorta. So if this is the aorta, so overriding of aorta means instead of arising over the left ventricle, aorta comes almost to the midline and arises over both the left as well as the right ventricle. So this is the overriding of aorta. And can you appreciate this right ventricular hypertrophy? So these are the 4 components of tetralogy of Fallot. So large unrestricted VSD, right? Pulmonary stenosis, overriding of aorta, and right ventricular hypertrophy. Now let us try to understand why cyanosis is occurring in tetralogy of Fallot. Okay. Now In tetralogy of Fallot, there is a pulmonary stenosis. So pulmonary stenosis, so lesser blood is going to the lungs. So lesser blood is getting oxygenated. So there is hypoxia. And hypoxia long standing leading to clubbing and cyanosis because of hypoxia. And the body also tries to compensate because of hypoxia by producing more and more RBCs. So polycythemia is also usually seen. Okay. So let us write down the clinical features of tetralogy of Fallot. Clinically, how the child will present. So it usually presents with cyanosis, clubbing, polycythemia, okay, and there is something known as cyanotic spells. So cyanotic spells are certain periods of times when the cyanosis becomes more severe. The child also has respiratory distress, okay, at that time. So cyanotic spell is a condition that can be seen in tetralogy of Fallot. We'll discuss more in detail about it because you also need to know the management of cyanotic spell. There have been questions on that, okay. So cyanotic spells can be seen. Remember, heart failure as such is not seen. It is not a feature of tetralogy of Fallot. So if you are given a list of diseases, heart failure is not seen in ASD, VSD, PDA, TOF. The answer is TOF. Okay, so tetralogy of Fallot as such, heart failure is not a feature. But it can be seen, of course, if it is complicated by certain other things like anemia, infective endocarditis, okay, myocarditis, and so on. So let us write down heart failure is not seen in tetralogy of Fallot unless it is complicated by anemia, infective endocarditis, myocarditis, or systemic hypertension. Okay. So heart failure is usually not a feature of tetralogy of Fallot. Now let us see what are the auscultation findings in tetralogy of Fallot. So what do you get on auscultation in TOF? Now even though a ventricular septal defect is an integral part of the tetralogy of Fallot defect, but no murmur is seen because of the ventricular septal defect in tetralogy of Fallot. Why? Because you can appreciate that the ventricular septum is so small, the two ventricles are acting like a single chamber, okay. So they are acting like a single chamber, so hardly any pressure gradient is existing between the ventricles, okay. So the two ventricles are actually acting like a single chamber, right. So hardly any pressure gradient is existing between the two ventricles. No pressure gradient, no flow of blood with a great, force, no murmur. So because of the ventricular septal defect per se, there is no murmur in tetralogy of Fallot. So what is the finding you get on auscultation? So we get a ejection systolic murmur in the pulmonary area because of the pulmonary stenosis. Okay. So let's write down. So auscultation tetralogy of Fallot, we get a ejection systolic murmur in pulmonary area, okay, because of the pulmonary stenosis, and we also get a single second heart sound. Why single second heart sound? So we hear only the aortic component of second heart sound because the P2 is soft and inaudible in tetralogy of Fallot. So P2 is soft and inaudible. Why is P2 soft and inaudible? Because one is the pulmonary artery is lying behind the aorta in tetralogy of Fallot. So you cannot hear the P2 very well. Plus only a small amount of blood is flowing across it. So P2, the pulmonary valve closes also softly. Okay. So P2 is soft and inaudible. So, single second heart sound is usually heard in tetralogy of Fallot. Now, how do you assess the severity of illness in tetralogy of Fallot? Let us see. So, the severity of tetralogy of Fallot is directly proportional to the severity of cyanosis. That means more severe the tetralogy of Fallot, more will be the cyanosis. But it is inversely proportional to the intensity and duration of murmur. Okay. Inversely proportional to the intensity and duration of murmur. Why? Because if the pulmonary stenosis is very severe, very little blood passes across it, so very less turbulence, lesser murmur. But if the pulmonary stenosis is not very severe, more blood is going across it, so more turbulence, more murmur. So when pulmonary stenosis is lesser severe, more murmur, pulmonary stenosis more severe, lesser murmur. So the severity of tetralogy of Fallot is inversely proportional to the intensity and duration of the murmur. Right? Now, so that is about the clinical presentation. So now coming to the investigation findings. ECG in tetralogy of Fallot, you may get right ventricular hypertrophy, but not very important for your MCQs. But what is very, very important is the chest X-ray in tetralogy of Fallot. Very, very important spotter. Okay. And multiple times asked in MCQs already. So let us see what you get in a chest X-ray in tetralogy of Fallot. Okay. Chest X-ray in tetralogy of Fallot. What you get is, so remember we said we have a cardiomegaly with right ventricle forming the apex. So apex is upturned like this. So when right ventricle forms the apex is upturned, giving the appearance of a boot-shaped heart. So classically in tetralogy of Fallot you get what is known as boot-shaped heart, or it is also called Cohen-Sabbat appearance. Cohen-Sabbat appearance. Okay. Plus, you get something known as pulmonary oligemia. Pulmonary oligemia. Oligo means less. Amia is blood. So, lesser blood is going to the lungs because of the pulmonary stenosis. So, the bronchovascular markings are lesser prominent in tetralogy of Fallot. So, that is called pulmonary oligemia. Okay. So, that is what you get in a chest X-ray in tetralogy of Fallot. So, now moving on to the management of tetralogy of Fallot. So, management of tetralogy of Fallot includes a medical management and a surgical management. And the medical management includes the treatment of cyanotic spell. So, first we should get an idea about the pathophysiology of cyanotic spell. How it occurs, what happens in cyanotic spell, then it will be very easy for us to understand and remember the treatment. Okay. So, let us discuss about the cyanotic spell. Cyanotic spell is also called Tet spell, as it is seen in tetralogy. So, Tet spell. Okay. Now, do you all agree to the fact that cyanotic spell or Tet spell is seen in tetralogy of Fallot when there is an increase in the right to left shunt? Now, in tetralogy of Fallot, a right to left shunt is already there. Yes? Right to left shunt means lesser blood going to the pulmonary circulation or right side of the circulation, more blood going to the systemic circulation. Right? Because of pulmonary stenosis, lesser blood goes to the lungs in tetralogy of Fallot. So, more blood goes to systemic circulation. So, tetralogy of Fallot, you have a right to left shunt. Okay. Now, due to any condition, if this right to left shunt further increases, then that gives rise to a cyanotic spell. Okay. So, if this right to left shunt further increases, then you get a cyanotic spell. Now, what is the situation in which this right to left shunt can further increase? It can increase if the pressure on the right side increases or if the pressure on the left side decreases, right? So, pressure in the right side increases if there is, say, pulmonary infundibular spasm. So, already there is a stenosis, more if it further goes into spasm, okay? So, pulmonary infundibular spasm. And pressure in the left side decreases. That can happen in systemic vasodilatation, which can happen due to sympathetic stimulation. In children, even crying can precipitate it. Okay. So, systemic vasodilatation, like you get even on crying in children. So, due to any reason, if this right to left shunt further increases, then you get a cyanotic spell. Okay. Now, what will happen if the right to left shunt further increases? That means further lesser blood is going to the lungs, further lesser blood is getting oxygenated, so more hypoxia. So the cyanosis deepens. So during cyanotic spell, the child will become more blue because very, very little blood is going to the lungs, very little blood is getting oxygenated. Okay, so you get severe cyanosis. Okay, so the cyanosis increases in severity. What else? So, what happens to the murmur in tetralogy of Fallot has been asked in the AIIMS exam previously. So, what happens to the murmur in tetralogy of Fallot spell, cyanotic spell? So, we are telling that right to left shunt is further increased in cyanotic spell. That means further lesser blood is going to the lungs in cyanotic spell. What will happen if lesser blood is going across the pulmonary valve? Lesser murmur. So during cyanotic spell, the murmur decreases or becomes absent. Okay, very, very important. So murmur decreases or may even become absent during cyanotic spell because very little blood goes to the lungs. Okay. Now, what will you get if you do a blood gas at the time of cyanotic spell? Okay, if you do a ABG at the time of cyanotic spell, what will you get? We'll get severe hypoxia, hypercapnia, and acidosis. Okay, so ABG, if you do arterial blood gas at the time of cyanotic spell, you will get severe hypoxia, hypercapnia, okay, and acidosis. Now, this severe hypoxia, hypercapnia, and acidosis, what will they do? They will go and stimulate the respiratory center in the brain. So, respiratory center in the brain stimulated. Okay. So, respiratory center in brain stimulated. So, what will happen? So, respiratory center in the brain is stimulated. So, it will ask the body to do more and more respiration. So, like that, the child will breathe. So, it is called hyperapnea, the opposite of apnea. Apnea means not breathing, hyperapnea means rapid and deep breathing. Hyperapnea. So, there will be hyperapnea. So, with the hyperapnea, more and more negative intrathoracic pressure created. So, more and more blood comes to the right side of the heart. And because the right to left shunt has increased, more and more blood goes to left side again. And so, this goes on as a vicious cycle unless you interrupt it with some treatment. So, that is the pathophysiology of cyanotic spell. Now, if we have understood the pathophysiology, it is very, very important and very, very easy to remember the treatment. Okay. So, let us see what is the treatment of cyanotic spell or the medical management of tetralogy of Fallot. So, treatment of cyanotic spell. Okay. Right. So, this hypoxia is causing problem by stimulating the respiratory center in the brain. So, give oxygen. So, moist oxygen inhalation. This acidosis is causing problem by stimulating the respiratory center in the brain. So, you give injection sodium bicarbonate to neutralize the acidosis. Okay. This stimulation of respiratory center in the brain is causing problem. So, you give drugs to depress the respiratory center in the brain. So, you can use morphine. Or in severe cases, you can even use ketamine. This systemic vasodilatation is causing problems. So, give drugs to cause systemic vasoconstriction. So, you can give alpha agonists like phenylephrine. Or you can give beta blockers like atenolol, propranolol, beta blockers like propranolol. Okay. Plus, a very important thing that we can do is, older children learn themselves. Whenever they are having the cyanotic spell, they will sit down on the ground in squatting position. What we can do in younger infants is we can fold their lower limbs and touch their knees to the chest. The knee chest position also helps in aborting the cyanotic spell. How does it help? So, if the lower limbs get bent like this, what will happen? So, two things. One is, the peripheral vascular resistance will increase, systemic vascular resistance will increase. So, pressure in the left side increases. So, right to left shunt decreases. Another thing is if you fold the lower limbs, some blood gets trapped there in the lower limbs. Okay, so more blood going to the right side of heart, that is not happening. Some amount of blood is getting trapped in the lower limbs. Okay, so this knee chest position or squatting position also helps in aborting the cyanotic spell. So, squatting or knee chest position helps in aborting cyanotic spell. So, that is the treatment of cyanotic spell, and we know why each of the following are used in treatment. So, moist oxygen inhalation, okay. So, oxygen to neutralize hypoxia, sodium bicarbonate for the acidosis, morphine and ketamine for the respiratory center, alpha agonist beta blocker to counteract the systemic vasodilatation, and squatting on each chest position helps by kinking the vessels of lower limb, so increasing systemic vascular resistance and trapping of some blood in the peripheries. Okay. So, that is about treatment of cyanotic spell. It has come as a question previously, all of the following drugs are used in the treatment of cyanotic spell except. So, you can see that there is no role of calcium in the treatment of cyanotic spell. No role of beta agonist like isoprenaline in the treatment of cyanotic spell. So, they are the usual answers that all of the following are used in treatment of cyanotic spell except. Okay. So, that is about the medical management of tetralogy of Fallot. Now, coming to the surgical treatment of TOF. Surgical treatment of tetralogy of Fallot. So, one is the definitive surgery and another refers to some shunt surgeries. So, the definitive surgery is basically the repair of the ventricular septal defect and the infundibular stenosis. Okay, so VSD closure plus repair of pulmonary stenosis. That is what is mainly done. What about the shunt surgeries? So, more important for your MCQs are the shunt surgeries. You get questions from there. So, shunt surgery, the basic principle behind it is, what is the basic problem in tetralogy of Fallot? Because of the pulmonary stenosis, lesser blood is going to the lungs. That is causing problems by causing hypoxia and all. Now, what you do in shunt surgery is you make a connection between aorta or its branch to the pulmonary artery. So, what will happen? More blood will go to the lungs. So, the symptoms of the child will subside, though you have not corrected the actual defect still. So, that is the shunt surgery. So, shunt surgeries are basically surgeries where you make a connection between pulmonary artery and aorta or its branch. Okay. There are some names, some examples of shunt surgeries which are often asked in the questions. Like recently in the JIPMER exam, a question was on Pott shunt connects which two structures. Okay. So, shunt surgeries, the examples are, so each of these shunts will connect pulmonary artery to aorta or its branch. Okay. So, it will connect pulmonary artery to, so one is the Blalock-Taussig shunt. It connects the pulmonary artery to the subclavian artery, which is a branch of arch of aorta. Okay. There's another shunt called Waterston shunt. It connects the pulmonary artery to ascending aorta. While there's another shunt surgery that is called Pott shunt. It connects the pulmonary artery to the descending aorta. So we can easily remember these by a mnemonic. बस वहाँ पहुँचा दो. Just make it reach there. So, bus, B with S, Blalock-Taussig subclavian. Waha, W with A, so Waterston shunt, ascending aorta. And pahuncha do, so P with D. So, in the Pott shunt, you connect the descending aorta to the pulmonary artery. So, these are very, very important shunt surgeries often asked in questions, okay, which connect pulmonary artery to aorta or its branch. So, more blood will go to the lungs and the symptoms of the baby will improve. Okay. So, that is about the surgical treatment of tetralogy of Fallot, the definitive surgery and some shunt surgeries. So, we saw the four components of tetralogy of Fallot are a large VSD, infundibular pulmonary stenosis, overriding of aorta and right ventricular hypertrophy. And we saw ASD is not a component of tetralogy of Fallot, remember? So, which of the following is not a component of TOF? ASD is the usual answer. So, we already mentioned while we discussing ASD that ASD is not a component of tetralogy of Fallot, but it is a component of pentalogy of Fallot and trilogy of Fallot. Okay. And there is one terminology called pink Fallot or pink TOF. Pink TOF refers to babies with milder variety, mild pulmonary stenosis, where the cyanosis may not appear very obvious. So, they may appear pink. So, that is pink Fallot. So, where the pulmonary stenosis is milder. Okay, so cyanosis is less obvious. So, that is pink TOF. So, these are the things that we need to know from tetralogy of Fallot. So, tetralogy of Fallot we saw is the most common congenital cyanotic heart disease in children, okay, and it usually presents beyond infancy with clinical features of cyanosis, clubbing, cyanotic spells, polycythemia. Then we saw the auscultation findings. We get a ejection systolic murmur in pulmonary area and single S2. Heart failure, not a feature of TOF. Severity, directly proportional to cyanosis, inversely proportional to murmur. Chest X-ray, boot-shaped heart and pulmonary oligemia. Then we saw why cyanotic spell occurs, and we saw the treatment of cyanotic spell. And finally, the surgical treatment of tetralogy of Fallot, which has a definitive surgery and the shunt surgeries. So these are the things that we need to know from tetralogy of Fallot for our MCQs.